Hello, everyone. Thank you for being here today. We'll go ahead and get started. Dr. Balas is the Associate Dean of Research and Dorothy Hodges Olson, Distinguished Professor of Nursing at the University of Nebraska Medical Center College of Nursing. She is an implementation scientist and registered nurse with extensive training and experience in the conduct of clinical trials and mixed methods research in the intensive care unit and hospital setting. The overarching goal of Dr. Balas's program of research is focused on improving the physical, functional, cognitive, and quality of life outcomes of seriously ill older adults. Her research endeavors specifically target developing, testing, and translating safe and effective interprofessional interventions aimed at reducing common geriatric syndromes, including hospital-acquired pain, delirium, weakness, falls, and infections. Dr. Balas's work has been supported by numerous federal and private philanthropic organizations, including the NIH, John A. Hartford Foundation Building Academic Geriatric Nursing Capacity Pre- and Postdoctoral Program, Robert Wood Johnson Foundation Interdisciplinary Nursing Quality Research Initiative, the Alzheimer's Association, and others. Her influence in transforming team-based hospital care of older adults and commitment to developing and testing evidence-based interprofessional interventions is also evident in her prolific publication record and leadership roles in numerous professional healthcare societies. Please welcome Dr. Michele Balas.
Good afternoon, everybody. It's officially 4 minutes after 12, so we've hit that hump hour. I'd like to take the opportunity to thank you for giving me the opportunity to present today. I'm going to pull up my slides here, and I'm seeing many friendly faces from the College of Nursing, so welcome. Okay, here. You guys seeing my screen okay? Wonderful. Yes. Perfect. So again, welcome, and thanks for the lovely introduction. In terms of disclosures, here they are, currently the R01s and my past honoraria. So what I thought I'd do with the group today is to briefly discuss my work over the course of the last almost 15 years now. Now, we'll be talking a little bit about the known harms of some of the things that we do to patients when they come to the hospital, in particular in the intensive care unit setting, and some of the findings of my research that's focused on dissemination and implementation science, in particular, this bundle of evidence-based interventions that we've been studying over the last few years. But more importantly, the presentation is not about the research findings per se, but more geared to maybe younger investigators or more experienced investigators who are starting a new interprofessional research team to kind of illustrate some of the challenges and successes that one may experience over the course of developing their research trajectory, how all funding is good funding, not necessarily just the NIH grant that we all want and get, but how programs of research can be built through different opportunities that we have. In particular here at UNMC, we are absolutely blessed with the number of funding opportunities that we do have. But most importantly, again, that focus on interprofessional research and what could be done if we bring teams together who have different experiences and expertise in advancing not only research, but in my case, patient safety and quality efforts. So I start with this old picture. This is a picture of the staff that I used to work with. So my clinical career was mainly in the intensive care unit. I was absolutely blessed with the opportunity to work at the hospital of the University of Pennsylvania in a surgical trauma intensive care unit. And I worked there probably for about 12 years, moved from medical surgical oncology to the critical care setting. But this is really where that interprofessional focus began. So at the time, in the early 90s, 2000s, we were doing things in the intensive care unit at this particular hospital that we're still trying to get people across the nation to do. And the biggest one was the interprofessional focus, the rounding, the talking every day. We cared for the sickest of the sick. And if any of you had experience in the hospital setting, you know, your clinical trajectory changes along with research trajectory. So in the ICU, you want to do all of the cool, fun procedures. You want to take care of the sickest of the sick patients, the patients on the ventilators that might have bypass and things like that. And then once you're in clinical practice for a while, your interests really do begin to change. In my case, I was always drawn to older adults when they were in the ICU, and I was always drawn to those patients that were confused or were not behaving normally when they were in the intensive care unit. So if an older adult came in and they were confused, the way it went was, oh, it's an old person, they're confused, give it to Balas. Balas loves those old people. Well, the reason I love those old people was we were super great at getting the most critically ill, complex patients over that immediate hub. They might come in with life-threatening injuries. We save them, only for them later to develop some kind of complication while they were in the hospital. And after years of watching the same trajectory happen, always triggered by, usually, you know, we knew something bad was going to happen if they'd have this change in mental status. I saw so many older adults and their families suffered in what, in my opinion, was unnecessarily, that I decided to go back to school and to get my PhD. And at that time, it was the idea of confusion being bad was relatively new. So it is very frequently, once an older adult is hospitalized, they do have an acute change in mental status. Back then, we would tell them and the families, oh, it's okay, they're old. When they come into the hospital, they're all going to get confused, but it'll eventually go away. And in fact, that wasn't necessarily true. But at the time, again, around early 2000s, the science of delirium was just developing. So my earliest research focused on first describing the incidence and prevalence of ICU delirium. So how many of these older adults that were seen so frequently in the intensive care unit, how many of them become confused, and what does that new onset confusion have to do in terms of their trajectory and their recovery after critical illness? So my pre-doctoral work was supported by the John A. Hartford Foundation, whose major goal was supporting the development of nurses who were interested in geriatric care. And my dissertation study looked at defining the frequency of confusion in older adults. So for my PhD work, it was big, right? So when I have expectations for scholarly work in a PhD program, it was a big study. It was a prospective study, and we enrolled 114 older adults in this study. We followed them every day they were in the intensive care unit prospectively. The PhD student, myself, went in and did objective measures of delirium. And we also did rather extensive chart reviews recording those clinical outcomes. And what we found in that initial work was, indeed, it was a problem. So we were one of the first to document what happened to older adults that had surgery, and, you know, a pretty aggressive surgery. We found a lot of them actually were admitted to the ICU with dementia. So dementia meaning that pre-existing cognitive impairment. When we talked to their family members, we found out many of them were declining over the years when we used this valid and reliable tool. Almost a quarter of them, as you can see up here on the screen. Interestingly, only 2% of those patients that we looked at actually in their chart was it documented that they're coming into the hospital already with some evidence of pre-existing cognitive impairment. So quite a disconnect there. One of the first studies to document that disconnect between what's in the medical record in terms of their cognitive impairment on admission, and then when you objectively screen what you find. We found over a quarter developed delirium while they were in the ICU. And that same amount developed at some time during their post-ICU period. So in other words, nearly half of the older adults in the sample developed delirium sometime during their hospital stay. So that's a big problem, right? But again, relatively new, just starting to document that the problem is out there. For my postdoctoral work, I was also blessed and applied and received additional funding from the John A. Hartford Foundation. And in this study, we extended our work on those patients that were in the intensive care unit to look at, okay, well, now we know that it is a problem for older adults. And what is the association between the development of this delirium and outcomes? So secondary analysis, great methodology for pre and postdoctoral work. We use the same sample that we did before. And what we found and was published in CHEST was that nearly a third of those patients who were admitted to the ICU, those older adults, had some kind of complication during their ICU stay. So meaning they either developed pneumonia or a DVT or a bunch of other complications that could come up. We also wanted to start initially testing to see, was there a relationship between confusion and the development of some of these complications? And actually what we found was people who became delirious during their ICU stay were at greater risk for being discharged to a place other than home. So either they unfortunately went to a nursing home or skilled nursing facility or rehab center, but they were much more likely to need some kind of institutional care post-hospitalization. Not surprisingly, they also had greater functional decline and again, more likely to experience those complications. So after my PhD and postdoc, I was recruited to the great state of Nebraska and took a position at the UNMC College of Nursing. And one of the opportunities that I had as a new faculty member was to apply for a very small seed grant. So in this case, you'll see here that we applied and got this $5,000 grant from the College of Nursing Dean's Research Grant. And what we wanted to do initially was to replicate some of the work that we did in our early studies in a new setting and to extend it to both medical and surgical patients. So here, I developed this wonderful interprofessional team. You may know some of these faces that are up on the slide right now, but generally speaking, we have experts in geriatrics, in critical care. And I always try to put up my statisticians because as you know, or if you don't know, you will soon learn as you begin your research career, how important having that statistician in actively involved in the development of the research before it starts, how important that is. So developed this great interprofessional team and had this small pocket of money. And we, again, looked at the number of patients that were admitted to medical and surgical units to see if older adults in a new setting were still at risk for the complication of delirium and what that had to do in terms of their recovery. And once again, with this small grant, we did find that, yes, it is definitely high rates of unrecognized cognitive impairment. So these people are coming in already with issues that were not being recognized or documented somewhere. Many of them were at risk for developing this delirium. And again, that delirium was associated with pretty poor outcomes. So that was again published in that time in another interprofessional journal. So while my career was developing and that initial focus in critically older adults in the surgical career, many other geniuses around the country were doing similar work, even in larger data sets on delirium. And there was also many studies that were coming out that were starting to think about outcomes that weren't traditionally followed in many ICU studies, right? So traditionally, intensive care unit studies focused on morbidity and mortality, not thinking of those outcomes that affect folks later down the line. Things that we know that patients and family consider very important. So again, what does their brain look like after an ICU stay months, if not years down the road? What is their, where are these people living a year or two? What is hospitalizations like? And the Gestalt building body of evidence is showing that we were getting really good as a community in helping people survive that critical illness, which is great, right? You got to live to have any other outcomes. So we were doing great as a critical care community at making improvements in terms of whether or not somebody would die when they come to the ICU. But then this new epidemic was developing, and the epidemiology supporting that was starting to get laid out, right? So now we have millions of people that are surviving a critical illness, but these people are developing disabilities that sometimes many would feel are worse than dying, right? Having severe cognitive impairment, living in a nursing home. And at the same time that this epidemiology and focus on longer term ICU outcomes, there is also increasing evidence that what we were doing in everyday clinical practice was in some way associated with those outcomes. So we knew that things like keeping people on a ventilator for too long was not a good thing. And that we should start taking every opportunity that we can to get them off early. Because a lot of the things that we were doing in trying to manage patient symptoms, or the way we managed ventilators, or the way we did sometimes what people would consider basic care, like whether or not we got a patient out of bed, was worsening those, or was associated, at least at that point, with worsened outcomes. So pretty interesting, this increasing body of evidence demonstrating poor long-term outcomes, and also the fact that what we're doing in the ICU is contributing to those longer-term outcomes. In 2005, the Robert Wood Johnson Foundation put out a specific call that was looking for research that supported research that looked at the effect, how nurses contributed to patient outcomes, and how nursing care was associated with quality of patient care. So they had this goal of supporting 48 different interdisciplinary teams. Again, if you're watching for funding mechanisms, I always tell people, you check 3 sites, right? You look at the NIH, what's the NIH funding? What is the Robert Wood Johnson Foundation funding? And now, what is Pete Corey funding? Because in the case of Robert Wood Johnson Foundation, they're often probably about 10 years ahead of where other funding agencies are going. So back then in 2005 now, they were really focused on dissemination and implementation science, quality, nursing, and most importantly, again, interprofessionalism, right? So these teams that, to be eligible for this grant, require you bringing together an interprofessional team. Now, one of the things that I've learned throughout my career is different professions define interprofessional differently. So when I'm reviewing NIH grants or grants from other organizations, there's a tendency in medicine to define interprofessionalism as a physician from cardiology and infectious disease and a physician from epidemiology coming together to do the research. They were very specific with the Robert Wood Johnson Foundation that definition of interprofessionalism needed to extend to different professions. So not just medicine, but nursing, respiratory therapy, biostatistics, whatever they were interested in. But they specifically required a bigger definition of interprofessionalism than is normally required. So we, again, developed this wonderful interprofessional team from various disciplines. Again, some of these faces might be recognized by many, but we had pharmacists, nurses, partners from the medical center where the study was conducted, experts in geriatrics and critical care. So really had this great team with multiple different perspectives that contributed to the development of the study and implementation of the study. We also had leading experts from interprofessional team members from around the country that were involved in this study. So again, this wasn't a really big monetary amount for the work we did, it was actually very impressive what we were able to do with a budget of $300,000. More importantly, the study only had 18 months. So we only had 18 months to develop this interprofessional team, conduct the study, and start contributing to the data. So in this case, what we did is we were focused on evaluating the safety and effectiveness of implementing this relatively new intervention that was developed. And this intervention back then was called the ABCDE bundle. If you're familiar with dissemination and implementation science, one of the key aspects with dissemination and implementation science is it's focused on evidence, right? And applying evidence into everyday practice. Well, a bundle is probably most known, most disseminated by and started originally with the Institute of Healthcare Improvement. The formal definition of a bundle is when you take a bunch of evidence-based practices and you put them together. And when you put these evidence-based practices together, you get better outcomes than if you were to deliver any single intervention, all right? In the ICU, we've had bundles before. We had bundles that are focused on sepsis. We had bundles that were focused on reducing ventilator-associated pneumonia, central line infections. The neat thing about the ABCDE bundle was the fact that it was not, and I'll tell you what the basic components are, but it was a very different type of bundle that we were going to test. And how is it different? It was different because it was not disease specific. So we developed this bundle for critically ill patients. It wasn't critically ill patients that a specific admitting diagnosis. It was for anybody who came to the ICU. What also was unique about the bundle is it was very team focused. To do the bundle required everyone from the interprofessional team's input in one way or another. So nurses, physicians, pharmacists, respiratory therapists. And it was also very patient-centered in the fact that it used always try to keep every intervention focused specifically on the patient rather than the provider's behaviors and needs. And it was also very flexible. So this ABCDE bundle back then, we were the first center in the country to ever test it. And the original bundle really focused on 5 major interventions, right? It focused on daily spontaneous awakening trials. So once a day, we shut off people's sedation. B was breathing trials. Once a day, we shut off a patient's ventilator. Sounds scary, right? If you're not in the ICU. C was we carefully selected what analgesics and sedatives a person would receive while they were in the ICU. D was we would assess and monitor for delirium. And E was early mobility. So focusing on getting people up and moving while they were in the ICU, as opposed to the traditionally method of keeping patients in bed during that acute phase of critical illness. Now, these interventions, again, were all evidence-based. Each of those interventions that I just described had randomized controlled trials supporting their effectiveness. So shutting off a patient's sedation and letting them wake up once a day works, improved, was associated with getting people off the vent earlier. Same thing with spontaneous breathing trials. So each of the interventions alone, we knew helped patients, but this was the first study to put them together in this nice, tight, sticky bundle to see if they worked. So in this 18-month pre-post study, again, that we did with only $300,000 at this time and a lot of patients by our clinician partners, we had 146 people before the bundle and 150 after the bundle was implemented into everyday care. And what did we find? We found, even with this really short implementation protocol, meaning that's comparing usual care before these interventions. Some of them were there, some of them were not. They were inconsistently applied to the start date of where we want every patient to get these interventions every day, we found in this initial study that even when that short implementation period, processes of care improved. So patients were more likely to get those evidence-based interventions, right? To have their sedation shut off, to have their ventilator shut off so that they could try to breathe on their own. So even in that short implementation period, we saw a change in process in the ICU care. We also initially observed that the patient outcomes improved when these processes of care, at the same time the processes of care improved, patient outcomes improved. So patients were more likely to get off the ventilator in the post-implementation 3 days earlier than those in the pre-implementation period. Most impressive, we saw that patients in the post-implementation period experienced half the odds of developing delirium. That's huge. We reduced the risk of developing delirium by almost half. One of the biggest reductions in delirium that was demonstrated in the literature to date. And then finally, again, with this initial test of the bundle, one of the more important findings was we were able to do all of these changes in processes without any adverse events. So people were very hesitant to do many of these interventions because they thought they might hurt people. And that's still a big problem today. You know, they're afraid that if you shut off the sedation, that the patient would be more likely to pull out their tubes, or that if you get somebody out of bed, they'll be more likely to fall, right? Or if we take somebody off the ventilator too early, that might be a bad thing because they weren't ready and they might just wind up going back on the ventilator. And we didn't find any of those things happened. So this was a big finding, first in the country to test the bundle. The next study that I was involved in, we extended the work to 7 hospitals now. And interestingly, this study was done in community hospitals in the Sutter healthcare system. But we moved from that, relatively small sample size of 300 now to a sample size of 6,000 patients, and looked at, again, because this is early on, the bundle itself was still new, what happened when in that, when we compare patients treated with the bundle to those that were not, what happened to patient outcomes. And now in this multi-center study, we found a couple neat things. First, very consistent findings with that initial pilot study that was done at University of Nebraska Medical Center, meaning patient outcomes improved. But in this study, we also found out that, yes, we want everybody to get the bundle. Yes, getting the bundle as it's prescribed, meaning getting every intervention that's in there, is best for patients. But we observed this nice incremental improvement. So even if the patients got more and more parts of the bundle, so they went from getting maybe 20% of the interventions to 30%, we saw this beautiful improvement in patient outcomes. So for example, for every 10% the patients got some of those bundle parts, that is 7% higher odds of survival. And we also saw the more parts of the bundle that they got, the less likely they were to experience delirium. So this dose response was a really important finding, in addition to replicating the results in a bigger population. Once those two, very shortly after those 2 studies were conducted and published, the Society of Critical Care Medicine came out with their pain, agitation, delirium, immobility, and sleep guidelines. I was blessed. I was a member, committee member of the PADI's guidelines. I was actually on the agitation sedation section that specifically looked at the problem of agitation and sedation and the evidence surrounding the management and assessment of that. And I now, actually last month, just found out I will be serving as chair of this next guideline revision for the PADI's guidelines. But the PADI's guidelines came out from the Society of Critical Care Medicine. And in these guidelines, there was consistent, again, evidence being generated about the importance of evidence-based practice in the intensive care unit, specifically evidence-based practice as it related to pain, agitation, delirium, immobility, and sleep in the ICU. One of the conclusions of the PADI's guidelines was that we need interprofessional approaches to improve the care and outcomes of critically ill older adults, and also that those interventions need to be applied early in the course of critical illness. So because the studies related to the ABCDE were so new, they weren't specifically, there wasn't a specific question that focused on whether every patient should be getting this particular intervention, but there was mention towards that, the importance of this ABCDE bundle in terms of improving ICU survivorship. So while the PADI's guidelines were being developed and released, our team submitted multiple NIH grants that were looking at implementing the ABCDE bundle and studying it in a multi-center clinical trial. And each submission we put in got a great score, but that close, didn't get funded. And so we went through, I think, 3 different revisions of getting all this great feedback. Yes, this is important, but you need this. Yes, this is important, but just try tweaking this. And while we were going through the development, I don't know if you guys are familiar with the Gordon and Betty Moore Foundation, but billionaires from the West Coast. And unfortunately, Gordon had an incident where he was hospitalized and was in the intensive care unit. And guess what happened to poor Gordon when he was there? He developed a episode of delirium while he was in the intensive care unit. So the Gordon and Betty Moore Foundation, great foundational support in terms of providing money for research focused on hospitalized patients, great support for nursing research in general. But Gordon went in to the ICU, developed delirium, and the family is like, oh my God, this is a problem. What are we going to do about this? We are going to give some money for interprofessional teams to figure out a way so nobody gets delirium anytime they're in the intensive care unit. But we have one condition for that team to give this money to. There has to be a family component. Okay. Well, the Society of Critical Care Medicine and our team that's been working with the Society of Critical Care Medicine is like, wow, guess what? We have this great thing that could have helped Gordon if he got it while he was in the hospital. It's the A through E bundle. And what is the letter that comes after E? F. What if we put in an F for family engagement and family empowerment, and looked at the evidence surrounding what is the evidence in terms of adding family members to the bundle, meaning including them on rounds. So we presented the idea to the Gordon and Betty Moore Foundation, and they provided the Society of Critical Care Medicine with the funds necessary to do a nationwide study of this new ABCDF bundle that we modified to meet the requirement. See, serendipity, how this works out. Serendipitously, adding the family component of it. At the same time, because that evidence was developing and those PAD guidelines were expanding over the course of time, some of the bundle elements also changed. So the A changed from awakening to now assess, prevent, and manage pain, because there was more and more evidence that was coming out highlighting the importance of assessing and managing pain in the ICU. The B changed a little bit to both those spontaneous awakening trials and those spontaneous breathing trials, right? So the evidence is still there. We just collapsed it into getting the patient getting both of those evidence-based interventions. The C changed. It was still focused in terms of we care about what medicines the patients receive in the ICU, but we also know, we also knew at this point the importance of oversedation in the ICU. So more and more evidence came out since the development of that original bundle showing that the deeper the patients were sedated in the ICU, the worse their outcomes, right? So it is important choosing what kind of sedation you're using, but what we found, and this is how the bundle has evolved over time, is that, yeah, the type of medications matter, but what matters the most is how deeply sedated the patients are from getting those different medications. So the C did kind of change in terms of moving from particular choice of medications to more the choice of medications and how it affects sedation levels. D stayed the same, delirium, assess, prevent, and manage. E stayed the same, early mobility and exercise while you're in the ICU. This, however, was the first time that what E was described, meaning how was E operationalized? And in the case of the testing and the results that I'm going to show you about, we said that the E only counts this time if the patient sat at the side of the bed or higher, walked, moved around, whether or not they're on the ventilator. And then finally, we added that F. So in the F in the new bundle is now formally described that the family members were educated or participated in care planning for the patient, and that was documented in the patient's medical record. So with that Gordon and Betty Moore Foundation, again, not a ton of money here. This was a lot of in-kind voluntary effort. We did a multi-center nationwide study that eventually included 68 intensive care units. And these intensive care units were very diverse, meaning the regions of the United States that they were included in, the type of ICU they were. So we did medical, surgical, community, academics. We developed this huge database that each of these 68 centers who were just so wonderful and have contributed so much to the ICU literature today, they collected a ton of data in kind. I mean, no reimbursement whatsoever for the data collection that you're going to see. We were able to collect data on over 15,000 patients during this collaborative. And these patients had, again, a bunch of different diagnoses. And in terms of what we followed in terms of the process and outcome measures, we again we're primarily concerned, did the patients get the bundle as prescribed, meaning they got all those evidence-based interventions every day, or as like the ultimate goal? And also we looked at what percentage of the bundle elements did those patients get over the day. I'm not going to get into the particular findings. These are all published in that critical care medicine thing that you get here. But after working with these, again, 68 intensive care units across the country, guess what we found? This bundle cures everything. Cures everything. If you get the bundle as prescribed, this is showing you the complete bundle performance data. So they got it just as prescribed. Patients get out of the ICU earlier. They get out of the hospital earlier. They're less likely to die. Get off the ventilator earlier. Their symptoms are managed better. Less likely to be restrained when they're in the hospital. Less likely to have an ICU readmission. More likely to go home. Every single outcome that we predefined before the quality improvement project got better if they got the bundle. Everything, and huge dramatic improvements. We also, again, consistency of findings over time with your study is very important. We again saw that dose response in every single outcome we followed. So the more parts of the bundle they got, the better every single outcome, as you'll see here, got. The one exception being pain. They were more likely to have some episodes of pain. But again, that beautiful, look at the following slides. You'll see 100% of the bundle, best outcomes you could have. Third of the bundle, better, but not as good as anything higher. Every outcome, right? How long they're on the ventilator, their symptoms, their chance of having coma, their chance of having delirium, their chance of being physically restrained, except again for that pain. They did have a little bit more pain. So consistently finding these improved outcomes now, 68 centers, I have to tell you, even though we have all this great data, we still get the question, there's never been a randomized controlled trial testing the bundle, and there never will be. So God love you, go ahead and try. You can't do a randomized controlled trial with the bundle because it would not be ethical. There's too much evidence suggesting that people should be getting that. So clearly in my head and many others, indisputable evidence that the bundle should become standard of care in every ICU in the country, and it now is throughout the world advocated as standard of care. We had a ton of other questions that needed to be answered with this collaborative data. So what did we do? Well, we don't have any money from the Gordon and Betty Moore Foundation, but we have this extremely robust data set, and we have to answer all of these questions. So what we did was come back to the NIH, National Heart and Lung Institute, wrote an R01 and outlined all of the questions that we want answered in terms of the ABCDF bundle, and what are those factors that affect whether or not this bundle is adopted into everyday care. So we got the R01, and the first question that we asked, did participating in the collaborative increase ABCDF bundle adoption at a national level? So we had these great sites. They all tried their best. We threw every single implementation strategy at them during the course of the collaborative. Did bundle adoption change during the course of the collaborative? Important question, right? Important enough for the NHLBI to fund. And what we found is we were rock stars. We tripled ABCDF bundle performance, right? Rock stars, tripled. But oh my goodness, if you look what tripled means on this slide. So when we looked at the data pre-collaborative, how many patients in the nation were getting the complete bundle, getting these evidence-based interventions that improve every single outcome? 3% nationally. Holy moly, it's a problem, right? But we got up to 12% post. That's great. Look at that great performance. Pragmatism in me. 88% of the 88% of the patients in the country were not getting the complete bundle. Oh boy, do we have an implementation problem, right? And we saw that again consistently. So that's complete, and at the bottom is proportional. Yes, we saw a slow, steady improvement over the course of the collaborative. Yes, it increased bundle adoption, but boy, oh boy, we got a lot of work to do, don't we? So the next question we asked with the R01, and this should be published within the next month or two, is what were the bundle elements that were most difficult to implement? And it's not too surprising from an ICU clinician, going back to what I see as an ICU nurse. The hardest ones to implement were the shutting off sedation, right? Kind of hard to take care of somebody that's awake and could ask for things, as opposed to if they were completely snowed in a coma and aren't bothering at all with anything, right? So shutting off sedation, we're still really, really terrible at that, doing that in daily practice. We're still really terrible at shutting off that ventilator once a day to give them a chance to breathe on their own. And not surprisingly, we stink at getting people up and moving in the ICU, even though, again, improves a number of patient outcomes. But you can see how that those changes developed over the course of that 20-month period. And this slide also shows you where we need to go forward in terms of future investigations. Now, again, in this paper that'll be coming out, we asked the question, what happened at the end of the collaborative? Is it possible that there were some ICUs that were really good at doing the bundle and some that absolutely stunk? What is the proper English? And here's what we find when we look at that question. So indeed, there are some really good performers out there, right? In terms of doing the bundle and parts of the bundle. There's some people that are really great at doing that, a pain assessment, not really a problem, right? If we look at that element A, almost everybody's doing those pain assessments. But again, even if we look at something as hard as doing that early mobility, there's some intensive care units that do it better than others, right? When we're looking at them globally speaking. So that's kind of neat. Finally, in line with the whole dissemination and implementation line of research, the outcomes that we care about are a little different, right? We are caring about, whether or not the patients are getting the evidence that's being applied. So adoption, implementation, whether it's sustained in clinical practice, things like that, as opposed to the traditional just clinical outcomes like length of stay, death, stuff like that. But key to dissemination and implementation science, and key to any trial you're ever going to do, little hint, you have to have that qualitative component that explains some of your findings, right? So in all of these studies that we did with the bundle over the course of these years, we looked and asked providers, what are those barriers and facilitators? What are those things that stop you from delivering these known safe and effective interventions? And over the course, again, over my research trajectory, we've documented over and over and over again what those barriers were. And they're at multiple levels. At the clinician level, that fear that it's not safe to do these. Some more organizational issues, not having the right amount of respiratory therapists, not having enough respiratory therapists to physically do the spontaneous breathing trials, not being able to communicate with the physicians in a real-time manner. So a lot of factors appear to be influencing whether or not these providers deliver these safe and effective interventions. And I mentioned just briefly that, in the collaborative, we had these motivated, fantastic sites. I kind of told you, we threw out every implementation strategy we could during the course of the collaborative to see if it would increase adoption. Now, we didn't do any specific implementation strategy. We didn't focus on one. So we did provide them audit and feedback. We provided the data back to them on where their units were on a quarterly basis in terms of doing the bundle. We taught them the importance of engaging champions. We gave them all the education. So none of the sites had to develop their own educational programs. So out of the 68, known implementation strategy, I'm going to guess we probably did about 50 of them. At least taught the sites about 50 of them. But again, despite all those strategies, we still seem to have a problem with this at a national level. So again, if you're interested in the topic, I've attached more citations at the bottom for you to be interested in. But when concluding this talk, what I hope I demonstrated, particularly to the newer investigators that may be on this call, is how research trajectory can change over time, how opportunities sometimes arise in your career that are unexpected or just somehow seem to fall in your lap. For example, like the Gordon and Betty Moore Foundation, after the non-successes with the trying to convince the NIH of how important the question it was. And then how those opportunities then evolve, right? So if we didn't have the Gordon and Betty Moore Foundation, Gordon didn't have the ICU experience, we would have never we finally got the NIH grant, right? Now that we've documented the problem. But none of this would have been possible if we didn't have that interprofessional team. And those perspectives from interprofessional team members, not only in the grant writing, not only in the publishing, not only in the education and the dissemination that we've done over the course of the years on this ABCDE bundle, but how that develops as well over time. So I wanted to leave 15 at least minutes for question and answer discussions, but it looks like I only have 8. Surprise, surprise, but I was able to make it through even with the COVID the whole time. So I'd love to take questions from the audience if there's anything that might be unclear or you want my input on any projects or anything like that you're working on.
Hi there, I'll start out. I'm Jen Miller. I'm a new investigator. I love hearing about all the creative funding opportunities that you had. So one of the things that I'm genuinely interested in is if you think that your research would lend itself to comparative effectiveness research, if there's anything of the bundle that you could compare itself to, and if you think that this, if it's ready for like a PCORI grant or something like that, or if you could just speak on that. And thank you for your presentation. It was lovely.
Oh, you're welcome. It's funny because I just reached out to an interprofessional colleague from College of Public Health, and I think Dr. McCod was on before. So yes, so we had a meeting this morning about the next steps of our research, right? No, I firmly believe said and done, the bundle works. And there'd be no way, honestly, there's just no way to design a study that would answer the question whether or not it works. That's laid to rest in my head. Where we're going next is how do we get it better into practice, right? So we're going back now to implementation. Let's test an intervention that could actually get ICU providers to do it. So we're looking at an R01 that is out for behavioral economic strategies to increase adoption of evidence-based practice. But we're thinking bigger now. After my conversation with our College of Public Health statistician, we might even be thinking maybe U01. And in fact, it's funny that you mentioned PCORI, because given the data that we have collectively now, one of the considerations that I'll be talking about in this next meeting that I have in 5 minutes is, are we ready enough to go to PCORI for changing healthcare delivery systems? So yes, we are actually considering all three now. And what we're thinking about testing is the effect of audit and feedback, reminders, and education, and using a smart design, which I don't know anything about, but thank God the statistician does. And also bringing back in our College of Public Health colleagues the cost effectiveness of the different implementation strategies. So yes, 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 we're doing all three.
Very cool. Thank you.
Dr. Balas, I'm Denise Waterfield. I'm in Kearney, and I feel that the serendipity is just oozing in my office. Yes. Because I'm haven't had a chance to really sit down and talk to you, but working on a very similar part for my PhD dissertation, and more in the behavioral understanding and doing ethnography of the critical care nurses and those specific symptoms and the PADIS symptoms, and how hopefully have some results next year for that in that process, and just getting through the IRB right now. Because you have 4.5 minutes left, I was just wondering if you're open for a coffee. If I could come.
I am open for you fully, and I'm fully prepared now for your postdoc. Yes, and we have the data for your postdoc.
Awesome.
Yes,
okay. I'll send you an email, because I definitely want more than 4 minutes to ask some questions. So.
And I might have a ton of data that could supplement whatever you're doing now.
Awesome. Thank you. I'll be in contact. Thank you.
Regarding questions.
Yeah, regarding the ICU liberation data, is that a reasonably accessible data set, or is there pretty stringent restrictions on it?
No, the SCCM has the data. They will release it. I would warn you that if you go and get it from them, that would probably, the data wouldn't be as clean necessarily as we have now from the R01. But we do have opportunities to do additional secondary analysis with this data set based on any single question that one may want to offer.
Okay, thank you.
Yes, easily accessible. Well, I know people. I guess let me just say that we could get you it if you needed it. Well, thank you all again. And if you have any questions, I'll put my email in here. You could just pop me an email, and I'm more than happy to chat.
Thank you so much, Dr. Balas.
Yeah, thank you.
Have a great day, guys.